like to say I'm talking on a subject that is near and dear to my heart, but actually this is a subject that keeps me up at night worrying about my patients. So a deep venous thrombosis is a medical term for a blood clot. They occur for a variety of reasons. And it's when a cascade is triggered, causing the blood to adhere to the walls of your veins, which decreases blood flow. Common symptoms include generalized swelling, warmth, and pain in the region of the blood clot. Blood clots are common when a series of conditions known as Virchow's triads are met. They include injury to the veins, slower blood flow, or biologic predisposition. As you can imagine, a lot of these are actually met in orthopedic surgery. Why is this important? Well, there's a certain percentage of these blood clots which actually travel to the lungs and can lead to a pulmonary embolus. And it's been well studied that in patients who undergo general anesthesia, the rates of a fatal pulmonary embolus range from about 1/10 to 0.8%. And in hip fracture surgery, that can actually be as high as 7%. So how can we prevent this? We have both mechanical and pharmacological methods at our disposal. The mechanical methods range from graduated knee-high or thigh-high compression stockings, external pneumatic compression devices, venous foot pumps, and especially important is early mobilization. These have been found to reduce the incidence of blood clot by up to 60% alone. How do they work? So they decrease the stasis or the immobility of the blood as it pools in your veins. They increase the blood flow velocity, and they increase actually biological molecules which will decrease your ability to clot blood. These are not without disadvantages of using these methods alone, and the biggest disadvantage is it relies on patient compliance. So patients need to use these for extended periods as their effectiveness is dependent on the length of the use. They're also less effective on clots that are more proximal in the legs. And unfortunately, these are the clots that have found to be more deadly or more likely to cause a pulmonary embolus. So we also often use pharmacologic methods. Aspirin is a commonly used device. It's an effective platelet inhibitor at low doses. It has an advantage of being able to be taken orally, and it has no monitoring required, so it's very easy for patients. It's been found to reduce clots by up to 30% and actually pulmonary embolus by up to 40%. Coumadin is another oral anticoagulant that works by inhibiting a vitamin that creates other factors involved in clotting blood. The patient response to the drug is variant depending on biologic or other medications the patient is taking. So this does need to be monitored at a laboratory, which makes it more difficult for patients. But it is very effective, and it's been found to reduce distal clots by up to 60%, proximal clots by up to 70%. Unfortunately, it does come with a risk, and about 3 to 5% of patients experience bleeding complications. Heparins work by catalyzing the inactivation of factors involved in clotting. It's most commonly administered via intravenous methods. And the body breaks it down very quickly, so unfortunately it has to be monitored via lab to make sure you're in the correct pharmacologic dosing. It is reversible, but again, unfortunately, it's associated with about 8 to 15% bleeding complication rate. Lovenox is probably, in recent times, the most commonly used drug. It's a low molecular weight heparin. It acts similarly to heparins, but it's able to be delivered by a subcutaneous injection, so patients can go home while taking this medication, and it requires no laboratory monitoring, so it's much easier for patients. It's very effective, and it reduces pulmonary embolus by about 60 to 70%, and it reduces blood clots by about 70 to 80% as well. These are a few newer medications that we've been using. Xarelto in particular has been studied in an orthopedic population. It has an advantage: it may be taken orally and it doesn't require any monitoring. It's been shown to have an equivalent risk reduction in medications such as Coumadin and Lovenox in preventing blood clots. One concern, however, as the drug is new, is that it can't be reversed. Pradaxa is another drug that's relatively new to the market. Again, it has the advantage where you can take it orally, and it does not require any monitoring. It was recently approved by the FDA for the use in prophylaxis after a total hip arthroplasty. So again, while pharmacologic methods are very effective at preventing a blood clot, it is not without its risk. And so the main risks we worry about are bleeding, and that's bleeding not only in the perioperative period, but also, unfortunately, in orthopedic patients, there's a high risk of falling. And if you were to strike your head or injure another area, I mean, again, these are the things that keep me up at night. So it seems that this would be a very straightforward decision that we'd want to prevent blood clots, and we do. But as Dr. Berliner said, there's no free lunch. So unfortunately, it seems that we're stuck in between a rock and a hard place at times. And so we really want to focus and narrow down the patients that really need these pharmacologic methods. And so there's been a lot of debate about this, and the American College of Chest Physicians released a position statement to determine exactly which patients, or to clarify best practice options for who needs pharmacologic anticoagulation. The main points of the study are that for major surgery, anticoagulation is recommended for at least 2 weeks and up to about 30 days postoperatively. There's no consensus at all on which pharmacologic drug should be used for patients, but they did say that if there's a high risk of bleeding in patients, they recommended no anticoagulation be used. The European Society of Anesthesiology also released a position statement on patients of an older population and emphasized the role of early mobilization and mechanical methods in preventing these complications. So all in all, the decision to treat is basically based on a large risk analysis that a surgeon performs prior to your surgery. And risk factors for clotting includes a major surgery, immobilization if you have a personal history or a family history of a clot, and based upon these risks, we'll tailor the care towards each patient. So in summary, anticoagulation does save lives, but we need to weigh the risks and benefits associated with chemical anticoagulation. Thank you.